The following podcast is part of a certified educational activity titled New Insights: How Does Real-World Evidence Influence VTE Management? A visual exploration of real-world studies of DOACs. Access the entire activity and complete the post-test at peerview.com/URQ860. Downloadable additional resources are also available.
Hello, I'm Dr. Andrew Cohen from the Department of Haematology at Guy's and St Thomas's Hospital, King's College London, UK. Welcome to this educational activity on real-world evidence and its influence on VTE management. This is a patient of mine with a deep vein thrombosis, and what we can see here is a long serpiginous lesion that's translucent or dark in the femoral vein. And this is a deep vein thrombosis, a proximal one, that may break off and cause pulmonary embolism, as seen in this next patient of mine who has multiple pulmonary emboli, which are bilateral, shown in the left and right sides of the lungs. Both these patients would be suitable for a range of oral therapies or parenteral therapies, and both these patients would be suitable for DOAC therapy. So why do we need real-world evidence? Well, randomized trials on their own don't really reflect real-world practice and outcomes, and they don't include varied subpopulations with young people, elderly people, frail people, or those who are pregnant, nor do they capture physician practice and behavior. And so observational data complements randomized controlled trials by providing evidence of the effectiveness and safety in a more representative population of usual practice, giving insights into physician behavior and associated outcomes. And we find in real-world data that disease complications occur more often than the patients that are selected for randomized trials. If we compare randomized trials with real-world evidence, in essence, a clinical trial can tell you what a drug does, while real-world evidence can provide the context that tells really whether what it does actually matters. And if we look at these 2 points, we can see that randomized trials are sort of represented by this group of guards: well-regimented, strict criteria, strict protocols, carefully adjudicated events, and they tell us really how a product performs, but not reflective of the real world. Whereas real-world evidence is a bit more chaotic, like this picture of the running of the bulls. It's data collected outside of randomized controlled trials, much more diverse populations. It can be collected prospectively or retrospectively, and there's not strict criteria, and therefore we see a much broader range of patients. But however, it is possible that there's over and under-reporting of events. If we consider real-world evidence in terms of evidence in general, we can start with models or expert opinion, which is our lowest value evidence, and then move on to simple indirect trial comparisons or case series, and then move up to real-world evidence, which is not randomized like case control series or cohort studies. And these two strands underpin the data that we later get or earlier get, depending on how the data is collected, from randomized controlled trials, which sit at the pinnacle of the strength of evidence. However, we need that real-world evidence to support and be consistent with the randomized data. And there's a broad scope to real-world evidence. We can look at the severity of disease, the effectiveness of current and new options, their safety. We can look at the burden of disease in various ways like epidemiology or costs or quality of life. And we can look at subgroups that might get higher benefit than other subgroups. Real-world evidence may evaluate 4 main dimensions: effectiveness, safety, dosing, and adherence and persistence. But real-world evidence has its strengths and limitations. It is relatively inexpensive, and it is strong because it comes from clinical practice. And the databases are large the populations are diverse, you can have a broad set of outcomes, and the follow-up can be longer than that in clinical trials. But it's not enough on its own, and it needs to be looked at in combination with randomized controlled trials. Not just because there are problems like potential biases or coding errors, or there might be some residual confounding, but really what we show with real-world evidence is associations rather than determining causality. And there are ways to deal with bias in real-world evidence or non-randomized studies of interventions, because often we use this to compare what we call pharmacoepidemiological studies, and here we're comparing treatments. And we aim to reduce bias, and this can be assessed prior to the intervention due to the confounding of the groups or the selection of participants in the study. It can occur at the time of intervention, we can have bias, or after intervention with deviations from the intended interventions, missing data, the measurement of outcomes, and the analysis and the reporting of the results. It's important to say that informed decision-making isn't easy, but it is key to everyday practice. We start with the phase 3 studies, which are our randomized controlled trials. And generally, when they're done, we do indirect comparisons like network meta-analyses. And either at the same time or before or after the phase 3 studies, there may be retrospective database analyses. When drugs are registered, we can do registries of drugs and follow patients prospectively in either registries or prospective non-interventional studies. And all these factors go to informing the guidelines and expert recommendations. The question is, what does this all tell me, and is it the same? And it's not the same because, as I said, the phase 3 studies tell you whether a drug works, but the other studies, particularly the observational and real-world studies, tell you whether the way it works, whether that's actually important and impacts on practice. And generally speaking, when we undertake research, the process goes, as I showed you, from phase 3 studies round to real-world data and guidelines. But one of the examples I'm going to give today actually shows that the real-world data impacted on the phase 3 studies because there was experience using DOACs in cancer-associated thrombosis long before the phase 3 studies were analysed and reported. Let's move on to the second section of this program, and that's how does real-world evidence apply to the treatment and management of VTE? Well, this meta-analysis of DOACs for the treatment of VTE showed that in a series of 6 studies looking at the 4 most commonly used DOACs, they were just as efficacious as the standard of care in this meta-analysis, and there was no differences between recurrences or deaths when the DOACs were compared to vitamin K antagonists. But when we look at the meta-analysis of the major bleeding outcomes, we can see that overall, the major bleeding favoured the DOACs with about a 40% reduction in major bleeding. And this varied somewhat from trial to trial and program to program. But on the basis of this, DOACs became the treatment of choice for venous thromboembolism, mainly because of their improved safety profile. However, the use of DOACs varies in real-world practice from that in clinical trials, because in the clinical trials, drugs like apixaban and rivaroxaban were usually commenced within 48 hours or 2 days of the diagnosis. But here in this study looking at real-world practice, we can see in actual fact, the majority of patients switch on to rivaroxaban, for instance, around day 3 or 4 from the injectable treatments. And many patients switch up to 2 weeks. And this really reflects clinical practice, and it reflects doctors being concerned that patients might require parenteral therapy for a few more days prior to starting DOAC therapy. There are other examples of real-world data for venous thromboembolism, and in this study that we published 2 years ago, we looked at a comparison of apixaban versus warfarin in VTE patients. And in the clinical trials, we looked at just over 5,000 patients, but in this study, we looked at over 35,000 patients. And these patients were analysed following propensity score matching, which allowed us to produce something similar to a randomized trial in observational data. It's a pseudo-randomized trial. It still has the potential for confounding, but it gets closer to the truth than just comparing data that hasn't been well matched. And we use Cox proportional hazard models to look at the outcomes. And what we can see here when we look at the baseline characteristics is that the propensity score matching did a very good job of matching the important demographic criteria, the diagnostic criteria, the setting, and the etiology. And the results, as shown here, were entirely consistent with those observed in the randomized controlled trials. Here we see a reduction in recurrences of about 20%, which is consistent with the trials, but significant here because there were larger numbers. And we can see reductions in major bleeding, also consistent with the clinical trials. And we use network meta-analyses to compare data from randomized controlled trials when there aren't head-to-head studies. And this slide shows two grey dotted lines that cross, and where they cross is this efficacy and safety of the standard of care, which was parenteral therapy followed by vitamin K antagonists. And I'm going to show you comparisons of that with the DOACs for the treatment of acute VTE. And you really want to be in this bottom left-hand quadrant and as far deep into that quadrant as possible so that you can show improved efficacy and safety if that was demonstrated. If you're in the top left-hand quadrant or the bottom right-hand quadrant, then that's either a trade-off for recurrences or bleeding. And you don't want to be in the top right-hand quadrant where there are more recurrences and more bleeds. And if we take the Einstein studies, what we can see is that in these two studies with rivaroxaban, there was no differences in efficacy and safety as measured by clinically relevant bleeding in either of the two studies. If we look at the Hokusai VTE study with edoxaban, we can see that there is no differences in recurrences, but a probable reduction in clinically relevant bleeding. And if we look at the RECOVER studies, there were two similar studies with dabigatran, where we can see a reduction in clinically relevant bleeding and no differences in efficacy. And the same is true for the AMPLIFY study, where there is a reduction in bleeding and no differences in recurrences. But we can also compare across the studies, and we can see that all the studies, the confidence intervals for recurrences overlapped, but there is clear space between the AMPLIFY study with apixaban and the Hokusai study with edoxaban and the Einstein studies with rivaroxaban when it comes to looking at safety. Now, we can investigate this further in pharmacoepidemiology, and this shows the Ariel meta-analysis, which compared apixaban and rivaroxaban. And the first outcome that was looked at in 3 studies was recurrent VTE outcomes. And here we can see that the point estimate of 0.89 was not different and didn't favour apixaban or rivaroxaban, consistent with the randomised clinical trials. But when we move on to the analysis for safety, looking at bleeding outcomes, we can see that the point estimate for major bleeding and the confidence intervals did not include 1, and that there was a reduction, a relative reduction in major bleeding favouring apixaban over rivaroxaban, and also a reduction in clinically relevant non-major bleeding, also favouring apixaban with about a 41% reduction. Now, these studies are not randomised and they're not head-to-head comparisons, but we can clearly see that they're consistent with what we saw in the network meta-analysis. And in this respect, the consistency of the observational data complements the randomized controlled trial data. Now I'd like to move on to an example of how real-world evidence helps us manage patients. And let's take a case of a woman with obesity. And this woman had a body weight of 124 kilograms. She had a body mass index of 42, and she was being treated for a DVT and PE, and she's referred for further management. Now, the guidance from the International Society of Thrombosis and Hemostasis says in these patients we should check DOAC levels, and if you can't check DOAC levels, then not to treat them with DOACs. And the question we're asked is oral anticoagulation with a DOAC an option for this patient? Well, according to the international guidance, it may or may not be. And so we undertook some real-world data where we looked at 100 patients with obesity with an average weight of 139 kilograms and an average body mass index of 45. And these were patients with morbid obesity, super obesity, and even extreme obesity. And we measured their blood levels. And what this real-world data shows us is that they really had what we would expect with respect to peak and trough levels. Almost all the patients had trough levels within the therapeutic range. And also the peak levels were generally within the therapeutic range. And on the basis of this, we think that most patients with obesity achieve good blood levels of DOACs, and therefore it is likely that they're safe to be treated with DOACs, as with patients who are not obese. So here the real-world data helps us deal with deficiencies in the clinical trials because there are only few patients with super obesity and morbid obesity in the clinical trials. If we move on to cancer-associated thrombosis, this CT scan shows a large pulmonary embolism in the right hemithorax. And in this patient, we can see that this is an extensive thrombosis starting proximally and moving distally. And patients with cancer often have more severe thrombosis and often have worse outcomes, as in this next patient, where the autopsy showed a fatal pulmonary embolism. So we have some evidence from real-world data about how prevalent cancer is in VTE patients. And we know that somewhere between 15 and 25% of all VTE patients have cancer. About 10% have active cancer. And in studies like the PREFER study, which looked at a broad range of patients, about a further 16% had a history of cancer. So cancer is a very important factor in the overall burden of patients with VTE. And if we look in more detail at what sort of patients add to the burden of venous thrombosis that is cancer associated, we can see the more common tumours like prostate in men, breast in women, and lung and colon cancer in both sexes, they make up the highest proportion of all patients with cancer-associated VTE. But we can also see at the bottom of this table that tumours that are known to have a very high incidence rate of VTE don't make up such a great proportion of the overall burden. So pancreas, stomach and brain only add about a further 10% to the overall burden. And yet these are the tumours with the highest incidence. And so what the real-world data is telling us is that incidence is important because these are the patients where we might use prevention, but burden is what we're going to see in our clinics. And these are the patients that are going to live longer because they have less nasty tumours and are going to require longer-term therapy because they'll have the burden of cancer much longer than the patients with the more malignant tumours. We also have evidence from the randomized controlled trials of cancer-associated thrombosis that DOACs are effective and have an acceptable safety profile. In this meta-analysis from Gustozzi and colleagues, we can see that overall there was around a 38% reduction in recurrences in patients that received DOACs when compared to low molecular weight heparin. And overall, there was no significant increase in bleeding, but there were differences between the drugs with trends towards more bleeding with some DOACs and no increase in bleeding seen with apixaban. We can also look back at some of the real-world data, and this is the example I wanted to show you of real-world data driving the clinical trial data. Because between 2012 and 2015, even before the randomized controlled trials in active cancer patients were published, we can see that there was quite a lot of use of DOACs for cancer-associated thrombosis. And what we see in this North American study is that there's variation between which patients with which cancers get DOACs, with quite a lot of use in breast cancer and genitourinary patients and patients who have hematological malignancy, but reduced use in patients with stomach and esophageal cancers, pancreatic cancers, and also gynecological cancers and colorectal cancers. And so what we're seeing here is that the doctors are choosing their treatment based on their experience, because we know that patients with GI tumors and some urothelial malignancies are more likely to bleed with the DOACs than they are with the low molecular weight heparin. And this informed the clinical trials. And in many of the clinical trials, patients with GI tumors were either restricted in the inclusion criteria or excluded from the studies. So now let's look at an example of a cancer patient. And here we have a patient who's a 56-year-old man who's had chemotherapy for stomach cancer, but importantly, he's had a gastrectomy 5 months earlier. And he presents with an acute PE and is treated with dalteparin and referred to hematologists for further management. And the question that is asked is oral anticoagulation with a DOAC an option for treating venous thrombosis in a patient with gastric cancer? And the answer is, well, for some DOACs it is an option, and for other DOACs it isn't an option. And that really relates to what was seen in the clinical trials. And importantly, this patient has had a gastrectomy, so there's no residual tumors. So he may actually be able to take any of the DOACs, but generally speaking, we know there are variations in the safety profiles for the DOACs based on the randomized trials, but informed by the real-world evidence. Another example of real-world data and its use in active cancer patients comes from this study we published last year that looked at the safety and effectiveness of apixaban, low molecular weight heparin, and warfarin among VTE patients with active cancer. And we analysed 4 large US claims databases and used propensity scored matching and inverse proportional treatment weighting. And the outcome of this study, when we looked at safety, showed when apixaban was compared to low molecular weight heparin, we could see that the safety favoured apixaban over low molecular weight heparin. When warfarin and low molecular weight heparin were compared, there were no differences in safety, consistent with the randomized controlled trials. And when apixaban was compared to warfarin, we could see no differences at 6 months, but for the entire follow-up period, there was a significant difference favouring apixaban with respect to safety over warfarin. And if we look at efficacy, we can see for recurrent VTE that apixaban had about a 40% reduction in recurrences, entirely consistent with the randomized trials, not just of apixaban, but also of edoxaban and rivaroxaban, and that there was no differences in recurrences between warfarin and low molecular weight heparin. And yet, if you look further, you could see some differences with improved efficacy in the very high-risk patients that received low molecular weight heparin, but overall no differences. And apixaban was superior to warfarin. So this is reassuring data for the use of DOACs in cancer-associated thrombosis. And all this information from the real-world data and the randomized controlled trials fed into the guidelines and recommendations. If we look back from 2018 through to 2020, we can see the guidelines have evolved. So in 2018, the ISTH recommended edoxaban or rivaroxaban for low bleeding risk patients. And remember that the real-world data fed into the design of those randomized trials where we could see physicians practicing giving DOAC therapy, such as rivaroxaban, more frequently to the low risk of bleeding patients, such as those with breast cancer and prostate cancer. And in 2019, ASCO and ESC also recommended those DOACs or parenteral therapy. But by 2020, the National Comprehensive Cancer Network recommended all 4 of the DOACs and included apixaban and also dabigatran if the above regimens were not appropriate. And NICE last year recommended considering a DOAC if active cancer is confirmed in patients with VTE. So the guidelines have evolved and based on both real-world evidence and the randomized controlled trials. So in conclusion, the relevance and appropriate use of clinical practice or real-world data for VTE requires an understanding of the strength and the limitations of real-world studies. Real-world data helps us in supporting our treatment decisions in everyday practice, and generally speaking, the results from the DOAC real-world data analyses in VTE patients are consistent with the pivotal phase 3 randomized controlled trials, which are really our anchors for determining efficacy and safety. But noticeably, there are some differences when the DOACs are compared. I hope you found this activity informative and useful to your practice, and thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/URQ860. This activity is supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance. This activity is accredited by the University of Florida College of Medicine for Physicians and Medical Learning Institute Incorporated for Pharmacists. This activity is developed in collaboration with our educational partners, PVI, Peerview Institute for Medical Education, and the North American Thrombosis Forum.